Good morning, good afternoon, good evening for all of those that are joining us. We are here today with Dr. Nyjon Eccles, and I do hope I pronounced your name correctly.
Yeah.
I have been waiting for this day for all week. I was very excited to have Dr. Eccles join us today. And before we begin, just a couple of housekeeping items. If you do have questions after you watch this webinar, please feel free to shoot them over to me, and we'll make sure that we get them answered for you. I want to just take a moment before we dive right in, because we are going to talk today about women's breast health and thermography. But I want to take a minute to properly introduce Dr. Eccles. He is a conventionally trained medical doctor, is one of the most respected integrated medicine physicians in the UK, and has been at the forefront in the use of pioneering, innovative, and groundbreaking natural health care over the last decade. He holds many medical and academic qualifications, including MBBS, which is Bachelor of Medicine and Bachelor of Surgery for those that are not aware, and is a member of the Royal College of Physicians. He also holds a PhD in pharmacology. Now, over the years, Dr. Eccles has built a very large reputation as a champion for men and women looking to access a wider range of treatment and prevention options with their health. And I especially like that because men, unfortunately, sometimes get kind of put on the back burner with, hormones and things of that nature that we'll get into a little bit today. But he practices from a comfortable and welcoming clinic in Harley Street, central London. And today, Dr. Eccles is joining us from Spain. He specializes in Thermocheck Breast Thermography, natural menopause treatment, including natural bioidentical hormone replacement, better aging programs for both men and women. He believes the availability of a screening tool which helps women to detect risk many years before symptoms prevent themselves offers an unprecedented opportunity to reduce the ongoing rise in breast cancer occurrence because it allows the possibility of reversing risk through correct attention to lifestyle and key nutritional supplementation. Dr. Eccles writes and lectures regularly on topics that include natural cancer patient support, the medical benefits of good nutrition, breast health and nutrition, prostate health and nutrition, Thermocheck Breast Thermography, and natural anti-aging. He has been featured in Who's Who in the World annually since 2010 and was recognized in Who's Who in Medicine and Healthcare between 2011 to 2017 and 2019 for his outstanding contribution to the field of medicine. It is with great honor and privilege that I welcome you today with us, Dr. Eccles. So thank you so much for joining us.
Thank you for the invitation, and thank you for that introduction as well.
Absolutely. It is much deserved. So, and again, I want my listeners and my followers to know a little bit about your background. And I do encourage all of you that are listening to this today to please go out to his website. His website is naturaldoctor.org. We will put that in the notes after this is done as well, so that you can refer to it. But I highly encourage you to take a look at that. Dr. Eccles does some pretty incredible things to help support men and women's health. And of course, I'm very passionate about the thermography piece in women's breast and thyroid health. In addition to that, Dr. Eccles has been featured in many interviews and has given many lectures and seminars that are also recorded on YouTube. So please do your research, as I always say, and check him out. So with that, Dr. Eccles, we are at a point where we are at the end of September. We're getting ready to move into Breast Cancer Awareness Month, which I like to call breast health awareness, and leave the fear out of it, to empower women. So today I'd love to talk to you about your thoughts on, Thermocheck, what you're doing in your own clinic to help women, what women can do to help their own breast health, because again, as women, we've not been ever trained on how to look after our breasts, right? It's always been put your breast in a bra. They're there for, your partner's enjoyment as well as to feed children. And I'm being blunt, from a woman's perspective, that's kind of what you're taught, right? So we're not taught how to look after our breasts in a proactive, preventative way.
Mm-hmm. Yeah. So it's a huge topic, and it's a very important topic. And as you say, we're running into October. It's also breast. I like your breast health awareness. It's what it should be: breast health awareness, not breast cancer awareness. And that has always been a great passion of mine. Is doing what I do in sort of functional medicine is what can we do to detect earlier? How can we detect a stress that could lead down the road to something clinical? In medicine, we tend to generally detect too late. We detect disease. And one of my ambitions is always to be involved in technologies that detect earlier so we can then intervene earlier, do something about it, head the disease process off at the pass, and keep people safe, lower the risk. And that's really where I think thermography and the Thermocheck thermography, breast thermography that I do fits. It's detecting very early changes in the breast tissue that aren't necessarily a cancerous process at the time that they flag, but if left unchecked, could become that over time. And I think that's where people make the mistake comparing thermography to mammography. They're two completely different animals. Mammography is a breast cancer detection tool. By the time you see something on a mammogram, it has to be big enough to block enough X-rays for you to see it. By that time, in the majority of cases, depending on tumor division rates, it's been there 6 to 10 years. That's not early detection, and a lot of studies show that actually what we thought was a single tumor on a mammogram can turn out to have multifocal deposits in 2/3 of cases. So for me, we call mammography early detection. I don't think that's correct. I think what we have to do is detect changes in the breast tissue before they can become structural. And that's where I think not looking for structural change, but looking for thermal changes that might indicate an abnormal process going on in the breast gives us that early detection advantage. So since I discovered thermography, which is going back quite a few years now, 2004-ish, I was intrigued to know why this wasn't more widely available. I thought, well, you can criticize it, but when you drill down into it, it's giving us an opportunity to detect earlier because we're looking for those physiological changes, not structural changes. And secondly, what about younger women? 1/3 of breast cancers are now being detected in women under 50. In the UK, women are only offered mammography from 50. Well, what about younger women that are getting breast cancer who aren't offered a screening? So it gives us a wonderful opportunity, I think, to screen women younger, and two, to give us an earlier detection advantage. On top of that, if you detect earlier, as I alluded to earlier, if you detect early, you have a much better chance of stopping that process from advancing forward. And I think that's the key, not just in breast health, but also across the board. When you're talking about health in general, medicine should really be more about detecting a process which could lead to disease and therefore checking it rather than just detecting the disease. Unfortunately, it's the latter that modern medicine tends to be focused on. I think it needs to change.
Yeah, I absolutely agree with you. We're in the mindset, and that's what I share with people, as I'm trying to teach as well, prevention. If we're blessed enough that we continue to age, we've got two paths, and that path is either going to be, living a long life with health and vitality, or a long life with dealing with disease management, because that is unfortunately what our system is built upon is disease management and emergency health care. But that's too late, right? And then when you're in disease management, it's a much different pathway than if you're meeting, wonderful doctors like you, and you're learning new things and you're taking control of your health. That energy is very much more positive than the disease management side, where there's fear, anxiety, and you're just appointment after appointment, right? So there's a lot of emotion that goes behind that. And we know what stress can do to the body as well, too, because stress is cortisol, right? So we know what that does to the body as well. And, you were saying about, the 2/3, and it's absolutely incredible. And on top of that, women with dense breast tissue, I find I do a lot of educating on that, because that one's really important, because I'll let you explain that from a medical perspective, because That's very important for women to understand too.
Yeah, when you consider that probably half of women have dense breast tissue, it's very difficult to see a structural change when you've got dense breast tissue. And therefore, that's another drawback with mammography, is that if you have dense breast tissue, it's much more difficult to detect something abnormal in that dense tissue. But thankfully, we don't have that problem with thermography, because it doesn't matter how dense your breast tissue is. We're not looking for structural change. We're looking for heat changes. And they have no relation whatsoever to the density of the tissue. So again, we have another advantage there, given that, half of women have dense breast tissue. So, it's important to raise this, because dense breast tissue in itself is thought to be a risk factor, as you know. So, why some women have denser breast tissue than others, I'm not sure we fully understand, but there are obviously multiple factors involved in that. And at the end of the day, I think it's more important to know, well, how can we, irrespective of the density of the breast tissue, how can we preserve the health of the breast tissue over time? And I think that's another important part of the early detection story. What can you do to prevent women, generally speaking, how can you prevent them from running into trouble with a breast issue, a breast health compromise, or a breast cancer down the line? And that's been one of my passions, really, since I got into this, is not only early detection, but what on earth can you do about it? If you detect a woman who has a higher risk by an abnormal thermogram, it's no good just saying, okay, well, you've got greater risk, there's nothing I can do, come back and have another screening in 6 months, and you just watch the thermogram, persist. That makes no sense whatsoever. So part and parcel of offering early detection has got to be, well, what can you do about it if you detect a high risk situation, as in, and I believe that's what an abnormal thermogram represents.
Right. So great segue, because I was going to talk to you about that, because that's one of the things, right? People will always ask, okay, Catherine, well, if I come for it, well, and if it shows something, what do we do?
What do you,
right?
Yeah, exactly.
So, so what are some of the things that, some of my followers are going to probably listen to and go, gosh, Catherine has said this too, but it's only because of research that I do and people like you that I follow and I learn from, right? But I would love for them to hear from you, what are some of the things that show up, and how do you treat that so that women can be proactive and preventative?
So the way I came to this is I wanted to examine some nutritional elements in women who had abnormal thermograms. And the way I did that, I talked to a laboratory and I said, is there a home kit that we can send to women that can really, I was interested in vitamin D levels. I was interested in their iodine levels. I was interested in their omega 6-3 ratio, so the balance of essential fatty acids. And I was interested in how they were metabolizing their estrogens. And those 4 things we managed to get into a home kit test.
Fantastic.
So very, and in fact, we still have it. It's called Breast Nutricheck. But so I measured these 4 important areas of nutrition in women with abnormal thermograms, and I found almost invariably that women had a deficiency in at least 2, or an imbalance, I should say more accurately, in at least 2 of those 4 measured parameters. So it got me thinking, okay, well, if this is relatively common, then it should, and if this relates to the abnormal thermal patterns, why don't we see if we give women a correction to these nutrients as a standard when they have an abnormal thermogram, what would be the outcome of that over, say, a 6-month period? So what I did is I created some nutraceuticals, which I then gave to women who with abnormal thermograms, and then just brought them back 6 months later. What I found was that probably around 80% of those women would return in 6 months with either a normal thermogram or it would be normalizing in over 80%. So I knew I'd stumbled onto something quite important here. And we can't say that those women who had abnormal scans had a breast cancer, but we can say they had high risk. So what we're talking about here is nutritional ways that you can reduce risk in the breast tissue over, well, as little as 6 months. That's really what I think we're talking about here. And it's things like optimizing vitamin D levels, making sure no one has iodine deficiency, because both of those things, if they're deficient, increase your risk of breast cancer. There's no question about it. If you look at the data, there's plenty of data to support that. And then on top of that, it doesn't help you if you have an imbalance in your omegas. A lot of people in the West are too omega-6 dominant with not enough omega-3. And it's common to my measurement when I measure it in quite a lot of people, men and women, and it's common in the West to see an imbalance there. It doesn't help because if you have too much omega-6, not enough omega-3, that's a pro-inflammatory situation that can lead to not just greater risk of cancer, but risk of other degenerative disease and faster aging. So it's rarely measured, but it's an important measurement. And then, of course, the last thing, the estrogen metabolism, is also, I think, important because all women will break down their estrogens, even post-menopause. This is still applicable. All women will break down their estrogens in basically either a toxic or a non-toxic way. And you can measure that balance in those estrogen metabolites in urine. Very easy test to measure. Hardly anybody does it apart from people who are into functional medicine and understand this, but it's important because if a woman is producing a lot of these toxic estrogens have the potential to damage breast tissue and any estrogen sensitive tissue over time. And we know this is true because if you look at studies that have been done where they've measured these toxic estrogens, like, for example, without boring your listeners to the 4-hydroxy and 16-hydroxy estrogens, particularly those, the 2-hydroxy are safe. But if you look at breast cancer tissue, it heavily stains for some of these toxic estrogens, whereas the surrounding normal breast tissue does not. Studies show that. So what does that mean? Does it mean it's causal? No. Does it mean there's an association? Yes. So we might want to ask, why are there toxic estrogens in the breast cancer tissue, but not in the surrounding normal tissue?
Right.
Don't really know. But the point is, there is an association. So if you measure a woman to have an increase in the level of these toxic estrogens against the non-toxic, there are nutritional ways that can be corrected. It's actually what I call a nutrigenetic effect. It's where you're actually changing the expression of that woman's genes so that she starts to produce non-toxic estrogens instead of toxic. And that comes down to basically eating more cruciferous vegetables or supplementing with cruciferous vegetable extracts, DIM or indole-free carbinol, which is the phase 1 estrogen detox. And then the second phase of estrogen detoxification is methylation. And methylation is very heavily dependent on, for example, B vitamins. So often just supplementing B vitamins and cruciferous vegetables will disarm these toxic estrogens so that they don't damage your breast tissue. So none of that requires pharmaceuticals. But it's another way of changing risk. So that's what I do in my practice. So if someone has an abnormal thermogram, I'm thinking about vitamin D, I'm thinking about iodine, I'm thinking about what's the estrogen toxic ratio about. And even if I don't measure those things, I tend to intervene anyway and do that because there's no downsides to doing it in the majority of people. And so they tolerate these nutrients. And as I say, when they come back 6 months later, most of them are returning with normal thermograms over a period of 6 months, having started with an abnormal one. So for me, that equates to lowering risk. And then, of course, once they have a normal thermogram, I'll recommend they come back a year later, check your thermogram again, I advise them to continue some of the nutrient changes that I've recommended because it's going to lower their risk. And very often they'll keep returning with normal thermograms. So this, I think, it truly is a way to change the game here. With not waiting for a lump to appear, but assessing the breast health using thermography and intervening nutritionally to change the risk patterns over a period of time. I think that's the way to change it. People still aren't listening to this for reasons that are only clear to themselves, but it is, I believe, the way that we can change breast cancer risk moving forward.
Yeah, and it needs to, because the risks, I mean, the breast cancer just continues to rise. I do my research on it. I look at, the projection of the financials of some of the pharmaceuticals, and, they're by 2029, they're projecting to be $586 billion in revenue with 50% of that revenue coming from breast cancer. That was stated in their financial projection. So, it's very systemic. It's not, over the 50 years or so, we're not getting better. It's increasing. And, so a couple of things that you talked about, I just get so excited because epigenetics, I love looking into that, the methylation process. Most of my followers, they all know my story because I don't mind sharing it. But I had to dig really hard for mine too, to kind of figure out what was going on. I had, thermography said, this is what was happening, right? So there was fibrocystic activity. There was lots of hormonal influence happening. But yet on my structural test, again, this is not to beat up mammograms or ultrasounds in any way, shape, or form, or even my blood work, but fibrocystic activity along with high levels of hormone, influence, as well as a very cold thyroid. So what they consider, subclinical, because on my test at the doctor's office, my thyroid was within range, but you soon learn what within range means. It just means you're not at disease stage yet. And again, I've got friends that are doctors as well. They're trained in disease management, emergency healthcare. Well, we hopefully don't want to wait till we get disease, but all of those were accumulation, knowing that your thyroid requires iodine, your breasts also require iodine to be very healthy.
They do.
That was definitely one. But then as I added the iodine, I started doing the painting of the iodine on my breast tissue every day. I started the endocarbonyl 3. I was doing all the things, but I was still struggling with a little bit, and ended up doing a test and found out that I had a gene mutation on how my body methylated estrogen. So exactly what you're talking about. And it makes me wonder, Dr. Eccles, it just makes me wonder how many women have this gene mutation that their estrogens just aren't methylating properly. And as to your point, methylated B vitamins help significantly, right? But I had to learn that. And then from there, it was a wonderful journey, because then I knew my body better and I was able to really, truly impact my breast health. So it's quite interesting.
Yes. And everything you've just said, would you believe, not one bit of it is taught at medical school.
Interesting. Wow.
So I can tell you that's true, and it's still true, that the doctors are not trained in this functional medicine. It's a real pity, because I think physicians should be trained in preventative medicine. It's unfortunate that we've been led by the pharmaceutical industry into the treatment paradigm, which is you treat a disease once it's emerged. But, functional medicine is something, back here in time, where it gives us, when you understand this, you realize that actually, health can be preserved. Actually, you don't need to be one of those statistics. I read recently that by the time a person is 65, 80% of them will be on at least one pharmaceutical medication. And when you think about that, is wow. I mean, I believe that we can, we can't stop aging, but we can. But for me, anti-aging is not just about, looking good, having great skin, having great brain function, solid bones, and all the things everybody wants. It's about being disease-free.
Right. And
Better
having
aging,
vitality.
yes, is about being disease-free and having vitality so that we still age, but we age better, but then we don't age with a disease process either. I think that is possible, but it's not going to be possible wielding pharmaceutical medicines. We've got to be talking about prevention, what we do to prevent, understanding what we can do to prevent. And this ain't taught at medical school, at least not in the UK, it isn't.
No, it's not here either. I've got some friends that are doctors, and we've got these, some of these conversations, and it's definitely not taught in medical school because again,
Mm.
it's, as one of my friends who's a doctor, he said, Catherine, at the end of the day, he said, you're beating up a tree here because he said, we're taught disease management and emergency healthcare. Like when I
Yeah,
state those
yeah.
were his exact words. He said, that's just what we're trained. And, it is frustrating. He said, when we see client after client that we can't, seem to help, but they also have to take responsibility for their healthcare, which is
Mm.
key. Nobody's
Yeah.
there going to save you. You have to step up on the platform and say, okay, I'm here. I want help. Now, what do I do? And you have to be the one to instigate that as well, too, right? So,
Well, it's where I started out. I started as an emergency medicine physician, and I was at the other end of the spectrum because, of course, that's where medicine really comes to the fore and can save lives, and it does, and
absolutely.
we're not knocking conventional medicine, but somewhere we lost the message that, that it's all about treatment of disease, it's all about rescuing people. No, it isn't. It should be about keeping people well, so that they don't end up in that situation in the first place. So when I was doing emergency medicine, it was great. It was exciting. I felt like I could manage anything, that came through the door.
Yeah.
And then I thought, but hang on a minute, this is not rewarding. We're sending these people back out to come in again
Yeah.
without any empowerment on what they can do to prevent themselves getting ill. And I just thought, I can't do this. So that's when I flipped and I thought, oh, well, I've got to go back to the coalface, go back into family general practice, see patients at the coalface. And I ended up, spending my 5 minutes or whatever it was, trying to re-educate people on what they could do to improve their health rather than just giving them a prescription for a pharmaceutical. And in the end, it was just not sustainable to do that. I ended up setting up my own practice where I could really practice the sort of what I call, functional empowerment medicine that we're talking about here. We're talking about breast health, but it applies to so many different things. And but I get it's a bit frustrating seeing what's going on and seeing that we're not changing our focus very much. And I think it's because we're just being led too much by the pharmaceutical industry, who have to have a pill for every ill, you know.
Yeah.
But I think true medicine shouldn't be about that. It should be about physicians able to do the best for their patients based on the available evidence and not just, the pharmaceutical generated evidence.
Yeah. But I still believe that we are part of the paradigm shift. And I'm going to keep talking.
I hope so.
Everybody who will
I hope
listen to
so.
me, I will keep talking.
Yeah, I hope so.
I have a
Yeah.
91-year-old client, and she's given me permission to share her story. She started coming to see me when she was 89 years old, doing a full body scan.
Mm-hmm.
And she had shared with me when she was 50, almost 59 years old, she said, I laid on my couch every day. I was obese. I had lots of pills I was taking, handfuls every day. And she said, I kept praying to just, God, take me home. I was done. And she said, finally, one day, she's so sweet. She said, finally, one day I realized, you know what? He wasn't taking me. So I needed to deal with my own shit. That's what she said. But she said it was one moment where she decided, right? It was that paradigm for her that she decided she didn't want to live this way anymore. So she started making changes. And I will tell you, she is 91 years old. Last year, she went rock climbing. She takes no pharmaceuticals. She takes her vitamins. She walks 10K every day. She is in the best health of her life. And she said, Catherine, I'm so glad I didn't die back then because I'm having the time of my life. And so now she comes every year for a full body scan because she wants to make sure that she's going forward with longevity and understanding if there's anything starting in her body, then, she'll address it. But
Mm,
it just goes to show that you can, I tell people don't get so discouraged by where you are,
mm.
but it's start with one step at a time, and then over
Yeah,
time you can change it, right?
yeah,
So,
yeah, absolutely. And that's right.
okay. So I'm so sorry. I could talk to you for hours, and I know that you're in Spain right now and it's quite late there. So I just a couple of things that I want to kind of
Mm,
circle back on, okay?
sure. Yeah.
So on the thermography piece itself, you know, I have women will come for their, the first initial thermography scan. And then they're not real sure if, they should come a year later or 2 years later or, what have you. And I always explain to them, it's very important because if you have a persistent medium high risk, right? So kind of what are your thoughts on, yes, you have your baseline, but how important is your follow-ups afterwards?
Oh, it's critical because things can change fairly quickly, and we've seen that. I've seen that in my clients is where they present with. I had one just this week. Had presented with 4 years in a completely normal thermogram. The first time in her fifth scan, 5 years on, she
Wow.
has thermal abnormality in one breast, and it's like, where does that come from? So I think annual scan for me, annual scanning is appropriate. After all, if you think about dental checks, I mean, everybody in the UK, everyone's recommended to have a 6 monthly dental check. Why do you go? You go because just to pick up and correct anything that may be going awry in your mouth. Yes, so it's very much preventative. I mean, I never go every 6 months. I go once a year. But the point is, it's a preventative paradigm that you correct the decay that could go on if you didn't go. I think we should be seeing thermography in the same light, which is look at it like having a dental check once a year, where you're looking for any indication of degenerative risk or stress on the breast that you can then correct before you have your next thermogram. So I think that's what it is. It's a breast health tool, and that's important. I like how you started this. The difference between thermography and mammography is that thermography is a breast health tool, because if you have a normal thermogram, it's much more an index that you have healthy breast tissue. But if you have a normal mammogram, it doesn't tell you anything about your breast health. It only tells you you don't have a lump big enough to block enough X-rays. And there's the difference. So you see, and the other advantage, thermography, of course, has no radiation exposure. It's completely safe. You can use it even if you wanted to in pregnant women. I don't, because the breasts are so vascular in pregnancy. It's difficult to see what's normal and what isn't. So I don't encourage that. But it's safe to use. So non-invasive, safe, on repeat use. So completely different from mammograms, which are an ionizing radiation exposure. So, and in women who are premenopausal, the risk of exposing their breast to ionizing radiation is greater than postmenopause, because they're more sensitive to the radiation than postmenopausal women. So actually, if you're still premenopausal and you have a mammogram, you're at greater risk from the radiation exposure than if you're a postmenopausal woman. The studies confirm that. So this is a non-invasive approach, no radiation, no compression either, I should add. In a thermogram, there's no need for compression. It's like having your photo taken, but we're measuring heat coming from the breast tissue. We're not looking for structural change. So that means you can repeat a thermogram as often as you like, really, and with zero danger to the client. That's another huge advantage of this. So, and I'm not even arguing it should replace mammography, but it should be used adjunctively. It definitely could help us in the war against cancer in a preventative way, not just a detection way.
That's right. And you
Yeah.
had mentioned something earlier too about that. And, it's depending on which study you look at, right? It's like 6 to 8 years or 8 to 10 years. So yeah, it's always that range of 6 to 10 years before that lump is the size that's detectable,
Mm.
right? So by the time it's detected,
Mm.
it's got to be a billion cells big, right? So you've already got it. To your point earlier, that's not early detection.
No, it's
If
not.
you've had it for 6 to 10 years, that is not early detection.
Yes, and it's not even about early detection of breast cancer. It's early detection of a breast which is stressed. and could run into trouble. Everyone mixes this up, is that thermography isn't just about breast cancer detection. Yes, it can detect early breast cancers, but it also can detect thermal change that, if not corrected, can lead to a cancerous problem down the line. The studies show that. It was shown back in the 80s that if you take a cohort of women with abnormal scans and you just follow them over 5 years, they have a 40% increased risk of 40% of them had breast cancer within 5 years. That means that an abnormal thermogram represents a high risk position, and therefore it has to be taken seriously. It doesn't mean you have cancer, but if left unchecked, it could lead to that over time. And that's what we're talking about, is correcting the thermal changes. Even if those thermal changes mean you've just got some inflammatory change in the breast, not a cancerous change, it's not great to leave inflammation in the breast tissue over time. So you've got to correct it. And there are non-pharmaceutical ways of correcting those changes. I've demonstrated that. So there doesn't need to be a pharmaceutical solution to this. So that's part of the problem, I think, with this, is that we're up against a juggernaut that wants to provide a pharmaceutical solution for everything. And at this end of the spectrum, we're saying, well, actually, wait a minute. There are some non-invasive ways, nutritional ways, lifestyle ways of correcting these early abnormalities so they don't lead to a clinical problem down the road.
Right. Absolutely. All right. 2 more questions for you, and I'll let you go. How important, because I do know that some people do not use the cold water challenge. I myself am very passionate about that because I understand the science behind it. But from your perspective, how important is it for women to ensure that if they do reach out to get a thermography scan done, that the clinic is offering cold water challenge?
I'm quite adamant on this. I mean, there are some thermographers who disagree, but I'm pretty convinced, if you look at the data, that if you add a cold challenge, and what that's really doing is causing a stress on the body, just for your listeners, it's causing a stress on the body. An autonomic nervous system challenge is what you're doing, whether you hold cold packs or cool the room, however you do it. It's your body is stressed by this. And what happens when your body's stressed is the normal blood vessels constrict. But if you have abnormal blood vessels, such as the new vessels that tend to be part of the cancer development, those angiogenesis blood vessels, they don't have an autonomic nerve supply. So if they show us hot because of the increased circulation, they tend not to cool after you impose this cold challenge, whereas normal tissue will cool. Now, it's not definitive. It's not 100% definitive, i.e., meaning that if it doesn't cool, it means you've got cancer. It doesn't mean that, but it adds to the sensitivity of the test. And the data shows that if you add this autonomic cold challenge in, it increases the sensitivity to 95%. If you look at thermography, even back in the 80s, studies were finding around 90% sensitivity anyway. If you add the cold challenge, it takes it up to 95%. Why would you not do that? If you're a thermographer, why would you not add that extra precision into your procedure? That's what I say. And that's why the way I developed Thermocheck is it's built in. The cold challenge is built into the way the computer analyzes the images before and after cold challenging, and the computer automatically analyzes pre and post cooling data and generates the report based on that. You have to have it in because it just adds to the accuracy of the test. So for me, it's a no-brainer. It should be there. Why not have it?
Absolutely agreed on that. Absolutely. Thank you for that explanation. Okay, so as we try to get this wrapped up, this is just filled with like nuggets of gold through this whole video. So I hope the listeners, as you're watching this, you're taking lots of great notes because there's lots of information in here. So I know that a lot of women are going to say, okay, Catherine, how do I go and get my vitamin D and my iodine, all these things checked? So my question for you is, yes, you're in the UK, but I also have followers from all over the place, and some people don't mind, ordering things from the UK. So can my listeners, if they wanted to have the Nutricheck system, Are they able to order that through your clinic as well?
I believe so. I mean, it's not actually, the kit doesn't actually come from the UK, it comes from Europe.
Okay.
So actually, I think it's from Copenhagen. I think I'm right in saying that. So I believe that laboratory that supplies them already ships kits worldwide because they have
Okay.
connections worldwide. So I'm pretty confident, actually,
All right.
that the Nutricheck kit would be available.
Okay. So maybe what I'll do, listeners, here's what I'll do. On Monday, I'll go ahead through the order process and I'll order a kit for myself, and I'll do another live and show people the kit, and we'll see if there's any pushback from not getting it into Canada. How's that? I would
And if
love to
there's
show
and,
the kit
and if
myself.
you have if there is a problem, let me know because
I
I
just
can hopefully help to fix it.
Yeah, absolutely I will, because there's it's difficult for some people depending on where they live to
Mhm.
get, vitamin D testing done,
Mm,
your omega-6 and 3, and these are
mm,
all such important pieces, right? Even
mm.
iodine. I've searched high and low around here to see if there was a practitioner that did that. There was one, and then the lab that was out in BC had stopped doing it just
Ah,
recently, which is very,
pity.
very sad.
Mm,
So it's very, it's difficult, but I'm going to keep digging until we keep finding. But this sounds like a great solution too, if somebody wanted to. So again, for the listeners, I will put all of Dr. Eccles' information, his website information, and what he does at the bottom of the show notes. Please feel free to check it out. Again, go to YouTube, do a search for Dr. Eccles. There's incredible amount of training that is out there. It is to empower you to take control of your own health, whether that's your breast health, thyroid health, men's health, whatever it might be. There are so many nuggets of gold, Dr. Eccles, that you are training people on. And I'm so grateful that I came across one of your videos through Dr. John Campbell. So thank you. Was there anything else that you wanted to add here today before we wrap up?
one last thing, we didn't cover hormones, but
Oh,
just in two
that's huge.
sentences. Maybe we have to do another one on that. But but I have some videos talking about hormones and the difference between bioidentical hormones and synthetics, and
Yeah,
how that difference is critical.
it is.
So just because we're talking about breast and breast cancer, here's the nugget. 2005 International Journal of Cancer, 70,000 women almost studied, looking at the effects of different forms of hormone replacement therapy on breast cancer risk. It also looked at risk of clots as well. But let's focus on breast cancer. Categorically, what they found is that when you can, estrogen alone increases the risk of cancer a little bit, breast cancer. When you combine estrogen with the synthetic progesterones, and there are various forms of the synthetic progesterones, which drug companies have had to put in to patent the HRT. Yes, because you can't patent natural molecules. When you combine estrogen with these synthetic progesterones, what you saw is different rates of increase of breast cancer. But when they looked at the women that combined estrogen with natural micronized progesterone, zero increased risk of breast cancer. And also on the clot side, zero increased risk of clots, because the same correlation that they saw with the synthetic progesterones for breast cancer happened with clotting as well. So the message here is that if women can take hormone replacement safely, but they must take preferably a natural estrogen together with natural micronized progesterone. And that combination, the studies show, does not increase risk of breast cancer. And actually, most doctors, with all due respect to my colleagues, are still confused about this. They conflate all progesterones, whether it's natural or synthetic, as the same thing. They are not. They have completely different bioactivity in the body. So that's just in 2 minutes a summary of the key message with hormones and their influence on breast cancer risk.
And I have no idea how I missed that one because it's right at the top of my list of one of the things I want to talk about today.
Well, we tagged it in at the end, so it's
We
okay.
did, but I would love to have another, maybe another 30 minutes with you sometime during the month of October. Maybe we can do a series on the bioidentical hormones as well too, because I know it's a very hot topic for women, especially women that are in, perimenopause, postmenopause stage, right? And there's a lot of confusion around bioidentical hormones as well too.
There is. Well, we can certainly try and do that.
Absolutely. Sometime between now and Christmas. There we go. It doesn't have to be October, but definitely would love to have you back on again, and we'll talk about the bioidentical hormones because it's very important as well. So, all right, we are at the top of the hour. Thank you so much again, Dr. Eckles, and I hope you enjoy your rest of your evening in Spain. And for the listeners listening, thank you all so much. And just remember, you've got more power over your health than you are led to believe. So blessings to everyone. Thank you so much, Dr. Eckles.
All the best. Take care. Bye-bye now.
Bye.
Bye-bye.